Artificial Intelligence Doctor. User question. Does chronic inflammatory response around the leadless pacemaker electrode evolve over time, creating progressive fibrosis or encapsulation that increases capture thresholds independent of circadian rhythms or autonomic tone variations? Claude AI answer. Yes, chronic inflammatory response around leadless pacemaker electrodes does evolve over time, creating progressive fibrosis and encapsulation that increases capture thresholds independent of circadian rhythms or autonomic tone variations. This represents a fundamental biocompatibility challenge that affects long-term device performance. Temporal evolution of inflammatory response. Phase 1. Acute inflammatory response, hours to days. Initial trauma response. Tissue damage from electrode implantation triggers immediate inflammatory cascade. Neutrophil infiltration. Early recruitment of neutrophils to the implant site. Complement activation. Activation of complement system by foreign material. Cytokine release. Liberation of pro-inflammatory mediators, IL-1 beta, TNF-alpha, IL-6. Vascular changes. Increased permeability and vasodilation around electrode. Phase 2. Subacute inflammatory response, days to weeks. Macrophage recruitment. Transition from neutrophil to macrophage-dominated inflammation. Foreign body giant cell formation. Fusion of macrophages attempting to phagocytose electrode. Persistent cytokine production. Continued release of inflammatory mediators. Early fibroblast activation. Beginning of fibrotic response. Angiogenesis. Formation of new blood vessels around implant. Phase 3. Chronic inflammatory response, weeks to months. Persistent macrophage presence. Chronic macrophage activation and cytokine production. Fibroblast proliferation. Extensive fibroblast recruitment and activation. Collagen synthesis. Progressive collagen deposition around electrode. Myofibroblast differentiation. Transformation of fibroblasts to contractile myofibroblasts. Matrix remodeling. Continuous extracellular matrix reorganization. Phase 4. Mature fibrotic encapsulation, months to years. Dense fibrous capsule. Formation of thick, mature collagenous capsule. Reduced cellularity. Decrease in inflammatory cells, dominated by fibroblasts. Stable but progressive. Ongoing collagen cross-linking and capsule thickening. Vascular limitation. Reduced blood supply within fibrous tissue. Molecular mechanisms of progressive fibrosis. Key inflammatory pathways. TGF-beta signaling. Primary driver of fibroblast activation and collagen synthesis. NF-kappa pathway. Sustained activation leading to chronic cytokine production. PTGF signaling. Promotes fibroblast proliferation and migration. IL-1 beta/IL-6 axis. Maintains chronic inflammatory state. Matrix metalloproteinases. MMP's ongoing tissue remodeling and matrix turnover. Fibrotic cascade. Fibroblast activation. Transformation from quiescent to activated phenotype. Collagen type 1/3 synthesis. Progressive collagen deposition. Cross-linking. Aldol condensation and pyridinoline cross-link formation. Tissue contraction. Myofibroblast-mediated capsule contraction. Vascular regression. Reduced capillary density within fibrous tissue. Independence from circadian and autonomic variations. Structural versus functional changes. Permanent structural alterations. Fibrotic tissue represents irreversible structural change. Fixed electrical resistance. Fibrous capsule creates constant electrical barrier. Non-excitable tissue. Fibrous tissue lacks electrical excitability regardless of autonomic state. Mechanical impedance. Physical barrier to current flow independent of physiological variations. Contrast with autonomic-dependent changes. Circadian variations. Affect myocardial excitability and threshold, but not structural barriers. Sympathetic/parasympathetic tone. Influence cellular excitability, but cannot overcome structural impedance. Progressive nature. Fibrotic changes continue regardless of autonomic variations. Consistent threshold elevation. Steady increase in capture thresholds over time. Impact on capture thresholds. Mechanisms of threshold elevation. Increased electrical resistance. Fibrous tissue has higher resistivity than myocardium. Current dispersion. Non-uniform current distribution through heterogeneous tissue. Distance effect. Increased distance between electrode and excitable myocardium. Reduced current density. Lower current density at myocardial interface. Chronic strength duration changes. Altered strength duration relationship for stimulation. Progressive pattern. Early phase. Minimal threshold increase during acute inflammation. Intermediate phase. Gradual threshold elevation during active fibrosis. Late phase. Stable but significantly elevated thresholds with mature capsule. Continuing evolution. Potential for further threshold increases with ongoing remodeling. Clinical significance. Understanding this progressive inflammatory and fibrotic response is crucial for predicting long-term pacemaker performance. Unlike circadian or autonomic variations that are reversible, fibrotic encapsulation represents permanent structural changes that require device programming adjustments or potentially device replacement. Factors influencing inflammatory response. Device-related factors. Electrode material, titanium, platinum iridium alloys affect biocompatibility. Surface characteristics. Roughness, porosity influence inflammatory response. Electrode size. Larger surface area may increase inflammatory burden. Coating technologies, anti-inflammatory or bioactive coatings. Steroid elution. Dexamethasone-eluting electrodes reduce acute inflammation. Patient-related factors. Individual immune response. Genetic variations in inflammatory response. Comorbidities. Diabetes, autoimmune diseases affect healing. Medications. Anti-inflammatory drugs, immunosuppressants. Age. Elderly patients may have altered inflammatory responses. Tissue characteristics. Myocardial health and vascularity. Clinical monitoring and detection. Threshold monitoring. Serial measurements. Regular capture threshold testing. Trend analysis. Identification of progressive increases. Threshold variability. Assessment of day-to-day consistency. Safety margin evaluation. Ensuring adequate pacing output. Advanced monitoring techniques. Impedance monitoring. Changes in pacing impedance over time. Morphology analysis. Alterations in paced QRS complex. Evoked response analysis. Changes in captured response characteristics. Device diagnostics. Automated threshold trending algorithms. Management strategies. Preventive approaches. Optimal electrode design. Biocompatible materials and surface treatments. Steroid-eluting electrodes. Reduction of acute inflammatory response. Anti-inflammatory protocols. Perioperative medication strategies. Minimally invasive techniques. Reduced tissue trauma during implantation. Therapeutic management. Output optimization. Gradual increase in pacing output as needed. Safety margin maintenance. Ensuring adequate capture with appropriate safety factors. Alternative pacing sites. Consideration of backup pacing locations. Device replacement planning. Anticipating need for device replacement. Recognition of this progressive inflammatory and fibrotic response allows clinicians to anticipate threshold changes and implement appropriate management strategies to maintain optimal pacing function throughout the device's lifespan.